I'm going slideless, so I'm just going to stay here and hope it buys me like an extra 10 seconds because I need them. Thank you so much. It's such a privilege. This is an amazing day. I want to start by just briefly recognizing the CMS team members who are here. If you can raise your hands. A number of folks from our accountable health communities, integrated care for kids, and other work that this is highly relevant to are here. I know John wanted us to briefly mention what we were thinking about in terms of how we would present on ROI. And so I am going to stick to a fairly narrow focus related to thinking about the amount of savings to CMS, the federal portion of CMS generated by a dollar investment by CMS, but definitely recognize this is a complicated issue, and many of the points that George was raising, I think, feed directly into how we think about these issues, but also what the limitations are of the way that CMS usually contemplates ROI. So I want to say three main things today. One is just to focus briefly on the challenges of, as a payer, looking at ROI really for prevention in general, and I think social determinants of health sort of put a fine point on this, but it's a much broader issue. And, you know, we're really in uncharted territory figuring out how we want to do this in a value-based context. Somewhat notoriously, when CMS thinks about a new coverage decision, we don't normally think about it for a medical procedure based on cost effectiveness. And yet, as we are looking at thinking about prevention, we are often looking at it within this frame of trying to stay cost neutral and at least have an ROI of 1-to-1. And that, imposes a bunch of different constraints that are really important. And I think one thing that we find a lot is that we have to think very carefully about evidence, about targeting, and essentially about number needed to treat. So, you know, there's a lot of folks that are sort of like, well, of course we should pay for an air conditioner for a, beneficiary with COPD because that will keep that person out of the hospital. But as a payer, we have to also be thinking about, well, how many air conditioners am I going to need to pay for every one hospitalization that I can prevent? And so that is a big area that is, I think, often missing and in rapid evolution in the existing literature. We just heard 4 really impressive presentations about work and interventions that have demonstrated return on investment. But there is a much broader sea where we have much less clearly defined ROI and much less information to help us think about targeting. We've come a long way since 2014, 2015, which was when we were designing the Accountable Health Communities model. But in that model, as well as our diabetes prevention program and Million Hearts program, we've gotten totally reasonable pushback that we are not paying enough per person, and part of that comes from the fact that we've been trying to be relatively broad, but even there we've typically applied higher standards than in other interventions. So within the diabetes prevention program, for example, we are targeting a much narrower group of those with prediabetes than the CDC definition of prediabetes, and that was because we had to go in that direction in order to generate cost savings. In the Accountable Health Communities model, we're focused on those with 2 or more ED visits in the last year. And so that is an area, I think, again, rapidly evolving, but that we as a payer are looking for much more information, and also poses some challenges for us. And this kind of relates to the next point I wanted to make, because a lot of what we see are targeting that are based on social needs. And again, we as a payer are much more comfortable targeting based on diagnosis or maybe activities of daily limitation, but not necessarily based on, a housing need as a eligibility criteria for a Medicare benefit. So this is an area where, again, we're looking for more information about targeting, but that also poses some challenges for us. Because of all of that, and because of the challenges of trying to save more by paying more upfront in this kind of prevention model, we are really looking at opportunities to embed work on health-related social needs into value-based payment models. So, as an agency, we're working to eliminate fee-for-service payments, And so we're looking to delegate risk more to providers. Would highly encourage everyone. I think it sounds like it came up earlier today, but to check out the announcements we made Monday related to our new primary care work. We specifically put out a request for information on direct contracting, asking for information about how geographic attribution will create opportunities around social determinants investments, and very interested in more information there. But we recognize that as we delegate risk to providers and plans, it's also incumbent upon us to think about how we invest side by side in public health solutions and some of these infrastructure elements, because that can really drive a focus on very short-term ROI, and we want to make sure that we are investing in the health of our populations. And then my closing point very quickly was just to note that although I've talked here about the issues related to financial return on investment for CMS, we recognize that there are many other forms of return and also many other drivers of provider behavior in a value-based environment. So that some of these interventions, even if they are, say, cost neutral, may improve patient satisfaction, may improve provider satisfaction or reduce provider burnout, and may improve quality measures that we are paying on, so that there is a whole universe of drivers in addition to sort of classically defined ROI that are important here. Thank you.